Friends, we have the next session by Professor Theodoros Papasavvas, and the title for his topic is Cardiac Rehabilitation During COVID-19, Challenges, Opportunities, and New Norma. So before Dr. Theodoros starts to speak, I'll quickly share about him. He has received his degree in physiotherapy from Athens University of Applied Science in 2002. And he completed his master's in cardiac rehabilitation from the University of Essex in 2011, and PhD in sports and exercise psychology from the University of Essex in 2020. He has been working in clinical and academic settings, including his physiotherapy clinic in Athens, Greece, and the European University Cyprus in Nicosia, Cyprus. Currently, he's the program manager at Cardiac Rehabilitation Department in the Heart Hospital and Hamad Medical Corporation at Doha, and part-time lecturer at the Department of Physical Therapy and Rehabilitation Science, College of Health Sciences, Qatar University. Over to our speaker.
Hello, everyone. I hope you can hear me.
Yes, we can hear you, Professor.
Great. Thank you very much for this invitation. I'm greatly honored to participate in your esteemed conference. Delegates, participants, colleagues, I salute you from Qatar. Thank you very much again. This will be a very short journey on the COVID effect on cardiac rehabilitation, which is my specialty. And we'll see throughout this rather grim period some nice challenges that appeared and opportunities for the future. So by continuing, I can say I have no conflict of interest regarding to the content of this presentation. And we'll see the importance of cardiac rehab, the emergence of COVID and its impact on the services, staff, and patients. Recommendations that were given very, very shortly during that period. And then the call for cardiac telerehabilitation, and we will conclude with some thoughts as well. So, as you may know, ischemic heart disease is the first killer in the world. This is data from the World Health Organization. The latest is 2019 in this one, before COVID. We can see that the ischemic heart disease is the first cause of death. The data from the United States are a little bit more recent. They include the COVID as well here. So we can see in number 3 that you can see here, number 3, we have COVID. So in Qatar, also the country that we are practicing, ischemic heart disease is the first cause of death. So you can imagine that cardiac rehabilitation is quite an important service, and the physiotherapists that are engaged in this multidisciplinary team are providing a good service in humanity. So as you may know also, cardiac rehabilitation is a class 1 level A recommendation for most patients with heart disease because it reduces mortality, rehospitalization rates, readmissions, and improves quality of life, and all these things, as it is, of course, cost effective in most areas of the world. So the core components of cardiac rehabilitation, I will not stay long on this one, but you have to have an idea of what we're doing. We have the patient assessment, which is initial and final, before and after the program. The initial assessment serves to see the patient's needs and limits. So it serves for safety and efficiency and efficacy of our treatment. A very important part of the initial assessment is the symptom-limited exercise test, in which we stress the patient and see if there is any problems and see the limits, if there is, for example, any ischemia there, if there is any arrhythmia, if there's anything that is a ceiling on our practice, on our exercise prescription. Then the patient is enrolled in the program, and we offer nutritional counseling, weight management, blood pressure management, lipid management, smoking cessation, psychosocial management, physical activity counseling, exercise training, and then we evaluate our results and do a follow-up. So as you can see, this is a multidisciplinary service, but the core of this service is the exercise training here. This is a 3 times per week training, and this is conducted by physiotherapists and exercise physiologists. Of course, we were happy, and then we had COVID. You can imagine and remember these nice screens there. I will not stay long. What happened during COVID is when we started having the impact. It was in April to June 2020. Around 75% of cardiac rehab programs worldwide were suspended. So 3 out of 4 programs stopped. The remaining programs either ceased the enrollment of new patients, like our program, or reduced the components, like our program, or changed the mode of delivery from face-to-face to virtual, like our program, or shortened the program duration. Usually the patients stay for 3 months in the program, or the combination of all these things above. So it was a really severe impact on cardiac rehabilitations all over the world, and you can see the impact over here. This is a graph to show the impact in the States. You can see here, this is the number of sessions before COVID, and you can see what happened to the sessions during COVID. This dramatic drop from around 9,000 sessions per 100,000 Medicare beneficiaries to almost zero. Of course, it's jumped shortly afterwards, but you can see until the end of 2021, the service was not before the levels of prior to COVID. So it has a huge impact in our services. Some clinics, though, we need to admit and observe, like the Cleveland Clinic, which is a very famous clinic, continued their services, and they published a study, a presentation of their services that I'm just going to put here to showcase. These are the quotes from the study itself. They established an accessible, effective, and sustainable remote telehealth CR service for delivering uninterrupted care throughout the pandemic. They provided patients with routine and safe access to on-site cardiac rehabilitation, while closely adhering to the precautions between staff and patients. However, we need to notice here that the initial assessment that I mentioned in the previous slides, which is quite important, as I mentioned, was replaced by a virtual CR entry evaluation, virtual cardiac rehab entry evaluation. So the questions that we have here unavoidably is, can a virtual entry evaluation produce safe and effective exercise prescription? There is no exercise test there, as you can imagine. And of course, the everlasting question, ethical question, is there a conflict of interest in private healthcare? Obviously, the answer is known to everyone, but I'm very happy to entertain it afterwards. If we go, for example, in another clinic in the States, which is private but non-profit, which is the University of Vermont Medical Center, they also published their challenges and how they dealt with them. We can see that the mean operating profit per cardiac rehab participant pre-COVID was around $62. During COVID was minus, you can see the minus here, minus $421. You can see a huge damage to the clinic there. So the damage was caused because the program had the 17% deficit, and this deficit was because of fewer patients enrolled, fewer patients were allowed on site at any time, increased COVID-related costs, which were mostly cleaning supplies, masks, and signage, and the fact of the 19% of the initial consults were conducted via telehealth, which in the United States is reimbursed 67% less than in-person visit. So you can see what happens if less patients, less caseload is happening to the clinic, what kind of damage, financial damage the clinic suffers there. So we can always have this in mind, the financial perspective of the COVID-19 impact on cardiac rehab services worldwide. Apart from the impact on services, we had the impact on staff. The staff suffered a significant psychosocial and economic impact during COVID. The staff were anxious. They were afraid of exposing themselves and their family. Whoever participated and provided services in COVID-19 settings is very, very aware of this. They felt loneliness because they were isolating themselves in fear of contaminating and contacting the virus to other people. Many of the staff had problems with sleeping. Higher workloads in most cases resulted in increased levels of stress, and a significant percentage of the staff needed to continue to work because they were afraid of losing their job, despite the huge risk that they perceived. So they had to work, they continued to work despite the risk that they perceived. A quite important finding in this worldwide survey was that the sick leave was not paid in 1 in 5 cases. And again, 1 in 5 staff was permanently or temporarily laid off or had the salary reduced. So you can also see the impact on our staff there. And I cannot congratulate the staff enough for enduring this period. And obviously, we don't want this again. The impact on patients is also severe. This is a study in the UK, which says that during COVID, the probability of attending cardiac rehab in hospitals decreased 34 times, and participating in cardiac rehab in public gyms 15 times. So you can imagine the impact on the patients. And if you consider the benefits of cardiac rehab, you can there understand the consequences on mortality, readmission, and quality of life. So you can see the service almost stopped in the UK. And the problem was more severe in vulnerable patients, for example, patients in high risk or cognitive impairment. In rural areas, these patients had even a more problem because they were not able to participate at all. The diet was also affected because the patients were afraid to go out of their houses, to go to the grocery store and buy healthy food. So unhealthy diets were adopted with all the consequences that this has as well. Physical activity levels were decreased. As we know, we should all engage in 150 minutes of moderate intensity aerobic physical activity per week. Probably during COVID, this was not feasible. Exercise capacity as a result was decreased. Weight, body and fat percent were increased with all the consequences that we have. For elderly patients, again, family of patients that were severely impacted, we had frailty, standing balance, and lean muscle mass deteriorating. So you can see the dangers there, the risks of fall, and all the risks in the elderly population. And last but not least, we had the increased chance of depression because of quarantine. People were depressed. This is perfectly normal. And depression, as you know, is an independent risk factor for many diseases and affects the prognosis. So shortly after COVID, the societies, the cardiac rehabilitation societies, came up very quickly with recommendations. However, these recommendations, as you can see, are quite vague and general. For example, the European Society of Cardiology, I have put here the exact directions and recommendations from their site. You can see here that there is no clear information. This is just general advice. For example, be prepared to handle COVID-19 patients, deliver as much cardiac rehab as possible, develop and organize telerehab programs, detect and fight fake news, and all these things. So we have to admit that during the first period, everyone was really shocked and didn't know exactly what to advise. In the Netherlands, also, the Netherlands Society of Cardiology published again some guidelines. One important thing here is that we should perform the patient assessment and risk stratification with an exercise test whenever possible. So if not possible, you can use other tools and have an RPE, which is rate of perceived exertion less than or equal to 12 in complex patients without an exercise test. So the question is exercise with RPE 12 or less, which mainly is flexibility, coordination, muscle strength, is sufficient to invoke cardiovascular adaptations? Probably not. This is not an intensity that is sufficient to provide cardiovascular adaptations. But some say something is better than nothing there. If we go to Australia and New Zealand, again, we have some general recommendations that they are not providing any specific guidance. For example, include psychosocial intervention in cardiac rehab, retain e-health strategies after the pandemic, and so on. So there's no mention of exercise testing or exercise prescription. Last, we can see the Italian Association of Clinical Cardiology Prevention and Rehabilitation. You may remember that Italy was severely impacted by COVID. Again, the recommendations were not quite clear. They mentioned the assessment of functional capacity by the 6-minute walking test. And obviously, the question that arises here is the 6-minute walk test sufficient for risk stratification and exercise prescription? The 6-minute walk test is not a symptom-limited exercise test. It's a functional capacity test. We cannot determine the training heart rate zone from this. We cannot determine if the patient has reached the limits of ischemic threshold, for example, in most cases. Finally, in 2021, some light came out of the tunnel. The European Society of Cardiology convened, and they had a Delphi consensus from 28 experts. And they agreed and they assessed 150 statements and only agreed in 49% of them, which is quite interesting. As you can see, within the experts, even the agreement is not an easy thing. So the core components of cardiac rehab should remain the same. And we should provide initial assessment by assessing frailty and cardiopulmonary exercise testing. This is the new recommendation there. Inspiratory muscle training also, etc. So this is the most important recommendation, in my opinion, that after COVID, the assessment should include frailty and cardiopulmonary exercise testing, which is the gold standard in exercise capacity testing. Shortly after the COVID, there were many calls for cardiac telerehabilitation, and the European Society of Cardiology was one of the first organizations to mention this. So they issued a paper in April 2020, and they called it "The Future is Now, a call for action for cardiac telerehabilitation." And they quoted that the present call for action paper gives an update of recent cardiac rehabilitation studies and provides a practical guide for the setup of a comprehensive cardiac telerehabilitation intervention during the COVID-19 pandemic. The Europeans were not the only ones. Japan also stated through their cardiovascular society a call for cardiac telerehabilitation, because they also have a huge potential, because digital literacy is high and the infrastructure of telemedicine is already developed in Japan. In the States, I couldn't find anything other than instructions on billing on cardiac telerehabilitation, how to be paid, how to be reimbursed when you participate in telerehabilitation. So you can see the priorities of the societies across the world. This is a nice picture that I want to explain to you. This is the evolution of cardiac rehabilitation. In the 50s, we just have the traditional rehabilitation, which is the patient on a treadmill. Then we went into the 90s when we had the intensive cardiac rehabilitation. You can see relaxation techniques, diet, and hospital-based cardiac rehabilitation. Then in the 2000s, we had the mobiles. So we have some home-based rehabilitation as well with the hospital. In the 2010s, this happened more consistently. So we have the house, the hospital, the treadmill in the house perhaps, or the hospital and the mobile to see what's happening. And now we're going to the cloud. We're going to have the screen in the hospital, and the patient will be doing exercise at home, and their vitals through their mobile or their smartwatch can be in line and live transmitted to the hospital through the cloud, and we can see them live, which is what we're doing in Qatar at the moment. Cardiac telerehabilitation has advantages and concerns. Some of the advantages are greater privacy. The patient can do it at their own pace and time. They don't need to travel to come to the hospital. They are more independent. And if it's combined with telemonitoring, it is quite safe. There's, of course, protection from virus infection, and we can provide more of the core components at home, and we can tailor them as well. And the cost is low. So the concern is about digital literacy. Some of the patients cannot have mobiles, or they cannot function the mobiles, elderly population generally, reimbursement in some areas of the world, problems in integration with electronic medical records that can be, of course, superseded. It's less face-to-face interaction, so some patients may feel alone or not given too much attention. Some data safety and privacy concerns are always there. And of course, some lack of legal principles regarding what happens in case of emergency, who is to blame, and all these things. So if we can move on, you can see that the smartwatch here and the mobile here can transmit all these things that we mentioned. For example, exercise, they can transmit all the ECGs, the Borg scale, the heart rate, etc., to the dietitian for the weight and diet, all the lipids, scores, BMI, etc. For the physicians, we can see the blood pressure, the diastolic pressure, the mean blood pressure. For smoking cessations, we can see all the self-reported questionnaires. If the smartwatch allows, we can also see urinary cot9 and blood cot9 there, diabetes, and of course, psychosocial monitoring. You can see a holistic approach here, all the parameters and all the components of cardiac rehab being nicely observed and monitored, even, excuse me, even when the patient is doing exercise at home. So, do we have guidelines on cardiac telerehabilitation? We have some guidelines in 2019 from the American Association of Cardiovascular Prevention and Rehabilitation and the American Heart Association. Home-based cardiac rehab may be a reasonable option for selected clinically stable, low to moderate risk patients who are eligible for cardiac rehab but cannot attend the traditional center-based cardiac rehab program. So you can see here that as expected, the guidelines are conservative. They cannot say, yes, you can do everything with telerehabilitation, but we can do many things. When we have low to moderate risk patients, we can put them on telerehabilitation on the spot. So concluding, we can see that the pandemic created a severe disruption of cardiac rehab services worldwide, severe disruption like an existential threat, if I would say, to our services. And this crisis was treated differently according to the program. Every program adjusted its services in using clinical criteria or financial criteria, or both, as we saw. There is an acceleration of the pre-COVID shift from hospital-based cardiac rehab to online, virtual, home on telerehabilitation. You can say it as you want. This shift existed before COVID. The shift to home-based rehabilitation existed even before COVID, but COVID was a catalyst, if you want, and made many programs realize that this is perhaps the most viable solution in their services. But for this to happen, we have to have a symptom-limited exercise test, in my opinion, and several cardiac rehab programs in the world, even now, not only during COVID, but even now, do not conduct a symptom-limited exercise test to assess cardiorespiratory fitness. This poses a serious risk in safety and effectiveness of exercise. Safety, because we are not putting the patient on stress. We do not see the limits of the patient. We do not see if there's an ischemic threshold, for example, if there are life-threatening arrhythmias. And effectiveness of exercise, because we cannot have the true maximum heart rate of the patient. So we cannot prescribe the exercise according to the correct exercise zone. We cannot have the anaerobic thresholds. We cannot have any information that we can objectively rely on to prescribe exercise. And we're just ending up on giving exercise according to the RPE perception. Cardiac telerehabilitation could be the future cardiac rehab model for most patients with heart disease. And this is, again, supported by the guidelines. And can we go one step further? Can we say that should cardiac telerehabilitation be provided by default? So should this be the default option, telerehabilitation, and reserve hospital-based rehabilitation only for special occasions? For example, very high-risk patients who are not very literate in digital services, etc. I would say yes, perhaps it could be, but for this to happen, we need to have a good management of the underlying disease. So a patient who is fully revascularized. And of course, we should have a symptom-limited exercise test for which the patient should be stressed and check the safety of exercise before letting him exercise at home, for example. And ideally, we should monitor the patient during exercise, at least for the first sessions, through live ECG monitoring. The technology can allow this now. There's no problem, and we are doing this in the heart hospital in Doha. So yes, we can provide telerehabilitation, but these safety features that I described to you, in my opinion, should be mandatory. These are the references, and I would like to thank you very much for your attention.
Thank you, Dr. Papasavvas. If anyone has any question, or maybe then we can either wind up. Thank you, Dr. Ted, for your wonderful lecture.
My pleasure.
Thanks for taking out the time and sharing your expertise here with us. Thank you.